Bad news and good news. Bad news, we're talking acid base. Good news, you'll be finished. And you'll have lunch next. I'm going to try and make this simple because acid base is not terribly complicated. It seems that way, but then I think reading electrocardiogram is complicated because I don't do it often. But as we'll try and show you, how many people have been to London, England? And have you taken the subway? Mind the gap. Mind the gap. That's so you won't step between the train and the platform. And that's blasting all over it. Just remember that, and you've got acid base half solved. Mind the gap. Then we'll talk about the causes of non-gap and the causes of gap acidosis, and hopefully give you a reasonable approach. This is all going to be demonstrated by cases. 6-year-old boy seen for short stature is found to have a normal physical, except that his height is less than the 5th percentile. He was in the 25th percentile at the age of 3 years, has slowly fallen off the growth curve, and now he's below the 5th. His weight is now proportional to his height. A urinalysis shows a pH of 6.5, a specific gravity of 1.018, and his electrolytes are as follows. So he's got a bicarb of 18. Step 1, what is the gap? Well, that's the sodium minus a combination of the bicarb plus the chloride, and that's 13. The normal anion gap is 8 to 16. So in this case, there's a normal anion gap. If he has a normal anion gap and you assume that some of his growth failures secondary to an acidosis, which of the following is the data most consistent with? Chronic renal failure, diabetic ketoacidosis, a urea cycle defect with acidosis, or renal tubular acidosis? I'm a nephrologist. I'm going to talk about renal tubular first, but you're correct. Acidosis with a normal ion gap, I think in terms of threes, is renal loss of bicarbonate or GI loss of bicarbonate. Occasionally administration of urine of acid, which in this day and age is pretty uncommon. But renal loss of bicarbonate, three things again: renal tubular acidosis, type 1 or type 2, and we'll talk about that. Carbanic anhydrase inhibitor. And you say, well, we don't use many of those. Patients with glaucoma are often on Diamox, and topiramate is being used more and more frequently both for seizures and migraines. And it is a mild carbanic anhydrase inhibitor. And the last one is post-hypocapnic acidosis, which is seen primarily in the ICU and is probably not going to be of concern to you. GI loss of bicarbonate, diarrhea, that's a big one. Ileostomy, drainage, and digestive fistulas, patients with Crohn's disease that have a fistula. Ileoconduits, which we don't use much anymore. Administration of cation exchange resins. Okay. And an administration of acid, arginine chloride, which you can sometimes use to administer to provoke growth hormone. Parenteral nutrition, particularly if the prescription's not written correctly, and dilution acidosis, where you're trying, the patient's fluid overloaded and you're giving him lots of fluid, which happens in a post-renal transplant patient the first 24 hours. So you're given a normal ion gap, you consider the diagnosis of renal tubular acidosis for this boy who's not growing, and so you get a first morning urine and a blood gas. This is the urine. pH is 6, specific gravity of 1025. His glucose, everything else is negative. The gas shows a pH of 7.35 with a bicarb of 18 and a PCO2 of 36. These results effectively confirm the diagnosis of type 1, that's distal. Confirm the diagnosis of type 2, that's proximal. Exclude RTA completely, or establish the fact that there's acidemia without identifying the specific defect. Actually, you're a little ahead of yourself in terms of D is the answer I was looking at, and we'll look at that. Then you administer ammonium chloride and make him more acidotic. And repeat urinalysis then shows a pH of 6.5 with a pH of 7.29, a bicarb of 15, and a PCO2 of 34. This result, we can just skip this one. This would confirm the diagnosis of distal. He cannot acidify his urine in response to an acid load. That should be less than 6. And so, those of you, you jumped the gun, but you were right. Further history that would suggest distal RTA would be what? Father with a history of polycystic, mother with a history of stones, father with a history of anemia, a sibling who's in the 5th percentile, or a brother with posterior urethral valves. Good, mother with a history of renal stones. If you're an internist, we don't see this often in pediatrics, but we do see stones. But when you see stones, one of the things they tell you to exclude is a very mild distal RTA. And why is that? Because you're not going to sit there with lots of acid in your serum. So you stuff it in bone. And for every 2 hydrogen ions that you stuff in bone, a calcium, because it's a double charge, plus, comes out. With chronic deposition of hydrogen ion into bone, increased release of calcium, you have to get rid of the calcium, that goes out in the urine. You become hypercalcuric and you're more subject to stones. And so that indeed is the treatment for somebody who's got renal stones because of distal RTA. You treat the RTA and prevent stone formation. Type 1, it's an inability to excrete an acid load. And basically, to me, if your urine pH is never below 6, you know it. But you have to make sure they're acid enough to, their acidosis is such that it would be pushed to do that. Acid is accumulated and buffered in bone. Renal stones, it's a lifelong defect. It's more common in males. It's pretty rare, fortunately. Treatment is easy. You only need to give 1 to 2 per kilo of citrate per day. We all make about 1 milliequivalent per kilogram of body weight of acid per day. And so if all we have to do is neutralize the acid we're making, it's a relatively simple thing to treat. This is the board part. On any proximal or distal RTA, hypokalemia is the major issue. And that's partly because when you're acidotic, you've got aldosterone in that distal tubule all revved up. And therefore, you're trying to exchange potassium, sodium for potassium and hydrogen ion. If you then treat with a sodium-containing solution, you increase distal delivery of sodium. You can't get much hydrogen ion out, so what's left, you get potassium out. And so with treatment, you can often exacerbate a tendency towards hypokalemia. That's why we use combinations of sodium and potassium citrate when we treat. Okay. 2, a 6-year-old boy is brought to the emergency room in respiratory distress. He's breathing 44 times a minute. His respirations are deep. Physical exam shows he's moving air well, and there are no rowels, wheezes, or rhonchi. Blood pressure is 105/65, pulse is 110. His temp is 37.4, and his blood gases and electrolytes are shown. pH is 7.25 with a bicarb of 8 and a PCO2 of 23. Electrolytes, sodium 129, potassium 5.1, chloride 98, bicarb 8. Consistent with all of the following except Bingo. Acute renal insufficiency, salicylate intoxication, diabetic ketoacidosis are all gap acidosis. And step 1, you calculate the gap, and you get a gap of 23, which is clearly higher than normal. 2 causes of gap acidosis are increased production or decreased excretion. It's really pretty easy. So you get a gap, and now you do mud piles. For the first 15 years of this course, I used mud pies. I skipped the L because lactic acidosis, aside from the intensive care unit, was not much seen in pediatrics. Unfortunately, we now use a lot of metformin in overweight adolescents, and one of the complications of metformin is lactic acidosis. So you just go through the mud piles thing and think, well, what does this look like? And his blood glucose comes back at 473. The following therapy was instituted. He was given IV fluids. He was given 2 milliequivalents per kilo of bicarb IV over 5 minutes, and then he was started on an insulin drip. This was a child that was totally with it when he came into the emergency room, and when he arrived on the pediatric floor, he was comatose and unresponsive. The likely cause was hypoglycemia, hypokalemia, CNS acidosis, progressive dehydration, or hypercapnia. Good, C. This is the explanation. I apologize for this, but I am a nephrologist. I love the Henderson-Hasselbalch equation. The CSF usually has a slightly lower pH than the blood, and it's usually around 7.25 to 7.3. And essentially what happens is if the bicarb is 10 and the PCO2 is 26, and here and here things are okay, but then suddenly you give an infusion of bicarb very rapidly. What happens when you infuse bicarb rapidly? Whoops. What happens is you slow down your rate of breathing. So your PCO2 goes up. Bicarbonate goes up in the serum, but it has to be transported via active transport into the brain across the blood-brain barrier. So you've still got a bicarb here of 10, where you've got a bicarb here of 18. So essentially what you've done in the CNS is you've raised the PCO2 because that diffuses in immediately. So you've increased the denominator, you've kept the numerator the same, and pH is equal to the pK plus the log of this. So what happens is your acidosis gets worse. And I was, I'm old enough that initially we used to think, let's get people better really fast. Well, we learned that that's not so smart. And so we try not to do that. Of the following, which represents the best choice? Probably what you do is not on this slide, but that's the aggravating thing about boards, is you have to choose the best choice of 4 things, none of which you might do. Add no KCl to the fluid for the first 24 hours. Add 40 milliequivalents of KCl after the patient is urinated twice. Give another bolus of bicarb and add 40 milliequivalents after the patient is urinated. Change the fluids to 0.45% plus 50 of bicarb plus 30 of KCl after urination. You should be able to eliminate 1 or 2 of those right off the bat. Okay, whoops. Yeah, you can eliminate this one right off the bat. That's crazy. Because you know that as glucose goes down, acid base is going to get better, potassium's going to go into the cells. This is true, you want to give more potassium. You don't want to give a bolus. If you want to correct the acidosis and you feel compelled to do so, you do it with slowly. So you could do this, that's okay. But you also, like this, you need more bicarb or more potassium. So the critical thing is this. But the physiology is that you don't want to do anything quickly in terms of, and this, as I'm sure the previous talk told you, in terms of hyponatremia, hypernatremia, hyperglycemia. When I was a medical student, one of the internists looked at me and said, "Son, don't try and make them better any faster than it took them to get this way. You'll make more mistakes if you go too quickly than if you go slowly." Okay, this is a board question. And the answer is in this right here. A 3-year-old presents to the emergency department because of decreasing responsiveness, rapid respirations. He had not been ill, was visiting his grandmother's house. When it was time to get up from his nap, he was found to have rapid respirations and was very lethargic. What are you going to find? Anybody? Grandmother's house. If you see that in a board question, the only question is, what toxin did he get into? And literally, I was giving this talk to the residents at the Cleveland Clinic more than 20 years ago. I got this far and all their beepers went off. And the story was they were rushed to the emergency room because somebody was at grandmother's house, had gotten into mother's ditch. And so when you see grandmother's house, and sudden onset of symptoms, the only question is, okay, what did he get into? And this is your findings on exam. This is your findings on your acid base. And again, you look at the anion gap is 21. And you say, oh, it's a gap acidosis. And it's most consistent, it excludes everything except renal tubular acidosis, because that's a non-gap, and Rye's syndrome is probably pretty unlikely anyway. But it could be in terms of studies which would aid in making the diagnosis include which? For some reason, this is consistently on the boards. Salicylate. Salicylate intoxication is, and that will be, raise your hands, how many people have seen salicylate intoxication? Well, there's some young people. I've seen a lot of it, but that was years ago. How much have I seen in the last 10 years? Probably twice. That used to be relatively common. It's less common now, but it's always on the board exam. And this is always on the board exam. Treatment options that would increase the excretion of salicylates include all of the following except IV hydration and alkalinization of the urine, hemodialysis, administration of mannitol at 1.5 gram per kilo, or peritoneal dialysis. Which one does not increase salicylate excretion? Correct. Mannitol will increase urine output, but won't increase the excretion. The reason alkalinization works is because you're excreting acetylsalicylic acid. So if you alkalize the urine, you neutralize the acid and you can get more out. Hemodialysis is by far the most efficient way. You can take somebody that's relatively severely affected, and with aggressive dialysis, you can drive that level down in 2 to 3 hours. Peritoneal dialysis works, but it's much less efficient. KF is a 14-month-old female who presented with failure to thrive. She's 2.9 kilos at birth with APGARs of 9 and 9 at 1 and 5 minutes. She grew along the 10th percentile for about 6 months, but then fell off the growth curve and is now below the 5th percentile. Numerous determinations of her bicarbonate have been between 17 and 19. And they say, okay, does she have RTA? Her physical exam reveals a small girl with a normal exam. Head circumference is 50th percentile, but height and weight were the 5th. These are her electrolytes. Step 1, what is the anion gap? Shows a bicarb of 18. Just to go back, she's got a normal gap, 109 plus 127, so it's a gap of 14. So that's a non-gap acidosis. And a blood gas shows a bicarb of 18, a pH of 7.33, and a PCO2 of 32. The next step would be to obtain a first morning urine for urinalysis and pH, a repeat blood gas, a urine pH after ammonium chloride loading, or a 24-hour urine for phosphate and amino acids. Good. A first morning for what you're in, at least what I'm interested in as a nephrologist, is can she acidify her urine? And yes, ammonium chloride would do that. But if she can demonstrate that she acidifies her urine on a first morning urinalysis, which is likely to be the most acid urine of the day, I don't need to do any loading. A first AM urine showed a pH of 5. So you've now excluded, from my standpoint, it has a urine sodium of 70, a urine potassium of 27, and a urine chloride of 127. Serum bicarbonate at that time was 17. These values rule out the diagnosis of type 2, rule out the diagnosis of type 1, rule out both types of RTA, or rule out neither type of RTA. Good, rules out the type 1 RTA. I give you these electrolytes and I'll show you why. I don't think this is particularly useful, but it sometimes shows up on boards, more likely if you're taking the medicine boards, but it can be pediatric boards. What we are trying to find out is, does this work? And from my standpoint, if your urine pH is 5, it's pretty obvious that you are excreting hydrogen ion. You can't, because if you reabsorb everything here, your pH is 7. So the only way you're going to go from 7 to 5 is by excretion of acid on the distal tubule. So you've ruled out type 1. Internists like this for some reason in terms of, they talk about the urine anion gap. And all it is the fact that you've got one negative ion in the urine, chloride. And that has to be balanced by all the positives. So that's the sodium, the potassium, and this one, which is ammonium. And if you can't get rid of hydrogen ion distally, there will be no ammonia in your urine. And the chloride and the sodium and potassium will be equal. The fact that the chloride, when you subtract out the sodium and potassium and there's a gap, means that there's a lot of this, and that means your distal tubule is working. So that rules out two ways that the fact that there is not type 1 RTA. That's what the urine anion gap is all about. This is only good in chronic acidosis. If I make you acidotic by infusing acid or by doing something right now and measure this gap later today, it's still going to be negative, because in order for this part, in order for this to start working, it takes 24 to 48 hours. So it's only good in chronic acidosis. It's another reason I don't like it. But if you then got a simultaneous pH of 7.35 and a bicarb of 25, this would have them just give them a few seconds for this one. And we don't need 10 seconds. It's going to rule out both types of RTA. I think everybody knows that, because the bicarb's 25 and the pH is okay. If you started on sodium bicarbonate therapy or sodium citrate therapy, what's the side effect to be avoided? Make them key in an answer for this one, if only because it's going to be on the boards. And it's a short-term memory question. The big one is hypokalemia. You're going to increase distal delivery of sodium. You've got aldosterone all geared up. And when you put patients on therapy for renal tubular acidosis of either type, the major issue to be worried about is hypokalemia. You can also see it without being treated. It's rarer, and treatment, the thing that we need to watch out for is our treatment can exacerbate that. 4-month-old is seen in the office for recurrent vomiting that has become progressively more forceful and occurs with every feeding. You feed the baby and watch peristaltic waves cross his abdomen, followed by vomiting. Physical exam reveals a lethargic baby with poor turgor and a weak cry. His weight is 7 kilos, pulse 120, blood pressure 80 of 40, and respirations are 16. I would put you felt an olive, but I personally have never felt an olive, and I'm absolutely convinced. But the peristaltic waves I've seen. Which of the following electrolyte patterns do you think you're going to find? You can start the timer now. This is a dirty question, I will admit it. But most people got it right. You realize, with vomiting, he's most likely going to be alkalotic. Therefore, it must be C or D, because those are the two alkalotic ones. Why is it D? Actually, C has no gap. There's no anion gap, and that's impossible. So that's it. The other way that this will show up on the boards was not, pyloric stenosis is clearly the most popular, but a cystic fibrosis patient who's losing excessive chloride in sweat is the other way this shows up in terms of the same kind of electrolyte question. And the best approach to therapy is, he's 7 kilos, 10% dehydrated. We'll give you a moment to think about it. Okay, start the timer. C, okay. I would say it's D as well as it's D. They have massive losses of chloride. If you just think about what's happening. They're puking, hydrogen chloride goes out, and they're alkalotic. And until you replace chloride, nothing will get better. They actually need potassium chloride as well as sodium chloride. And so that's why I would choose D as opposed to C. They did this with medical students in the 1950s. They put NG tubes down, they put them on a clinical study center, and they drained gastric contents. They did that for a week, 7 to 10 days. And then they fed them a chloride-deficient diet. They maintained their alkalosis for another 10 days until they replenished the chloride. We did some pretty beastly things in the prior years to medical students, and that was one of them. But in terms of what they demonstrated was you absolutely have to replenish chloride before you're going to correct the alkalosis. And that's why prior to surgery, we're so aggressive in terms of our fluid management, in terms of getting rid of the alkalosis. Okay? You actually see a 6-year-old girl. I actually saw this patient. She'd lost weight without a change in appetite. She's drinking water constantly. Growth and development were normal. Grandmother has type 2 diabetes. Physical exam is normal in the 5th percentile for height, and she interrupts the exam twice to drink water. The story is consistent with renal insufficiency, diabetes mellitus, diabetes insipidus, or hypothyroidism. Diabetes insipidus. Diabetes mellitus is the one thing is she's drinking water, she's lost weight without a change in appetite. Most diabetics have a change in appetite. They eat. And this girl had the following electrolytes. Now what do I do? Serum osmolarity is there's only one answer that this can be in this. Correct. It can only be 315. 2 times the sodium is already 302. And then you have to add in the other anions, which are at least 10. If you want to get precise about it, you end up taking 2 times the sodium plus 10, plus the glucose divided by 18, plus the BUN divided by 3. It's actually 2.7, but 3 you can do in your head. In most cases, the glucose and the BUN don't add much if they're normal. But in abnormal circumstances, you need to do that. The next step in evaluation in this patient is to obtain a urine osmolarity and serum osmolarity. Have the patient come into the office first thing in the morning to obtain these studies, but allow her no fluid overnight. Administer intranasal DDAVP and repeat the electrolytes, or admit the patient to the hospital and perform a water deprivation under controlled conditions. Key in an answer. Most of you got it right. It's either A or D. I would do A because if this urine osmolarity is way out, is 1 point, is 200. And the serum osmolarity is high, you know that you've got a problem, and you know what it is. If the patient doesn't concentrate her urine following admission to the hospital and following water deprivation, then what do you do? Administer DDAVP, place her on a high-protein diet and repeat, obtain an MRI, or continue to deprive her fluid until she has lost 10% of her body weight. Yeah, you give her DDAVP to see if she'll respond. The one thing I want to sort of caution you against in terms of if you're going to water deprive somebody, you must do it in the hospital. The true patient with diabetes insipidus will, in 12 hours, can lose 7 to 10% of their body weight. And if you do that overnight, it can be very dangerous if they're not under. When we do it, we weigh them every hour or two, and we repeat electrolytes every 2 hours. And if they lost 7% of their body weight, they're done. Then we give them DDAVP to see if they respond. This girl, we did all this. She had diabetes insipidus, and then your next thing is obviously an MRI. I saw this girl when this course started. There was no MRI. In fact, CT scans weren't very good. We knew she had DI. We knew there was a tumor, and it took us 2 years to find it on CT scan. A 12-year-old boy is admitted from the emergency department for treatment of a depressed skull fracture after falling. He weighs 50 kilos, has multiple bruises, but no other fractures. A normal chest strain, normal urinalysis, and IV fluids were started D5.2 plus 20 of KCl at maintenance rate. 12 hours later, he had hyponatremia with a sodium of 127, potassium of 4.9, and electrolytes is shown there, normal creatinine, normal BUN. The most likely result of water intoxication, inadequate sodium replacement, diabetes insipidus, or inappropriate ADH. Inappropriate ADH. And that, you can argue about using 0.2% normal saline. It would have happened with when you have inappropriate skull fractures, trauma is is often concomitant with inappropriate ADH, and they will retain water and get rid of in excess of salt. Initial treatment should consist of which? You can read these and then I'll have him start the timer. Bingo. People want, whenever I see patients, people always want to fluid restrict, and they talk about, well, let's just do 3/4 maintenance. If you really want to correct their sodium, you got to really cut their fluids to insensible loss. Because they're going to retain, if you give them too much water and they have ADH, they're going to reabsorb the water. What is the free water excess? I think Reed probably went over this with you. I used to use this very complicated equation, which is the first few lines of this. You always assume two things. The number of sodium molecules is absolutely correct, and the only thing that's wrong is how much water you have. And this is true for hypo or hypernatremia, either too much or too little water. So when you assume that, you could calculate out the number of sodium ions and then redissolve them and figure out to a system of 140. You'd get 2.78 liters. The other thing you can do is use 4 or 5 mils times the change in sodium that you want, times their weight, and you come out with the same thing. So this in red is much easier than that, anything else. And you can use either 4 or 5. But that will give you, and you can see that it comes out to 2,600 as opposed to 2.78 liters, 2.6, close enough for government work, and a whole lot easier. You can do it in your head without doing all this math. But it's based on the assumption that the number of sodium molecules is correct, and the only reason you have hyper or hyponatremia is either a deficit or an excess of water. So this works either way. So if you had a hypernatremia, you could go 156 minus 145 times the weight times 4, and you'd come up with approximately the deficit. And you don't have, it'll be in the ballpark. Done. Okay. Good luck